Now, our next speaker standing beside me is Molly Hinshaw, whom I met about 28 years ago when Lewis told us about this wonderful woman he had met. And it was an apt description then and now. Now, Molly calls me Mum, M-U-M. And I think it's because she hopes I live up to that name and remain silent. You don't get everything you want, honey. I truly have much love and respect for Molly. She's also one of the hardest working people I know. As an example, when she and Lewis were in med school together, she gave birth to 2 wonderful grandchildren for us. That takes a lot of extra effort, needless to say. She's an accomplished dermatopathologist at the UW Medical School and also contributes actively to many programs to benefit underrepresented groups. Today, she will advise us on how to care for our skin and nails like she would. Please give a warm welcome to Molly.
Thank you. Thank you. Well, thank you all for having me. It is my great pleasure to be here, and aloha. And thinking about this visit and our time here was just reminded of my initial, basically at birth connection to Hawaii when my mother and father chose for me my godmother, my aunt Bev, who is Hawaiian, and who taught me to hula at this young age, me and my cousins. And subsequently, my college roommate, Jerusha Malema Mekaleona Henahe Hagen, is born and raised on Oahu, a beautiful person who also shared with me many stories and taught me some lei making and other things. My hula isn't any better than it was when I was about 5, so I still have to work on that. But in any case, she's here on the island with her family, and Lewis and I chose to honeymoon here. Almost 23 years ago. So we've had the great pleasure to come back for many other visits, and I'm thrilled to be here today. I'm going to start with my disclosure, which you already know is my beautiful mother-in-law, and to her left, her namesake, my daughter, our one and only Audrey Virginia Hinshaw, and you've already seen actually an image of Dr. Robin Dothit, and other friends from Madison. So I'm thrilled to be here to speak with you today about dermatology. And essentially, as I was crafting this talk today, I decided, basically what I'd love is for us all to feel like we are great partners in our healthcare and consumers of dermatologic care, so to make ourselves better consumers in that regard. So I welcome any questions at the end, and I hope that we can share some things as we go in terms of thinking through how to take care of our skin and nails. So to begin with, we're going to think like a dermatologist thinks. And how many of us have ever seen a board-certified dermatologist or a dermatologist? Wow! I apparently have many more than have had to have ablation. So I don't go as deep as Lewis goes. If I hit the liver, I'm in trouble. So, but in any case, well, that's great company. The large majority, fantastic. We're going to talk about photoprotection. We're going to talk about the importance of early detection, healthy aging, dry skin care, and nail care. So to begin with, when we see skin, the dermatologist is thinking about multiple layers, the 3 layers of skin. And these are important because these relate to everything, whether it's a rash, or in dermatology we use the word dermatitis frequently. That's sort of a synonym for rash. We are talking about this top layer of skin, and this is perfect for Dr. Leong here, who is, of course, a pathologist and who could be giving this part of the talk better than I could. But in any case, epidermis is the top layer, the dermis is the second layer, and the fat, or the subcutaneous layer, is the third layer. So when a dermatologist is talking about skin, this is what we're talking about. Just to mention initially, when we're talking about in situ cancers, specifically melanoma in situ or squamous cell carcinoma in situ. That in situ means it's contained in the top layer of skin. So that's another relevant thing to remember here. Anytime we breach the second layer of skin, which we frequently do, because as you can see, these little interdigitations of the light pink to the brighter pink, those digitations are called dermal papilla, and those are collagen. This is where all the collagen lives. So if you have any skin surgeries or even that cold cryotherapy that Lewis was talking about for the skin, you risk a scar that would be superficial. But most skin cancers, in fact, all invasive cancers, get to some depth in this second layer of skin. And then the fat, I put in here, again, it's a layer of skin. So when we say skin, this is what we're talking about. So the subcutaneous layer here, this is what an actual histology image looks like when your dermatologist takes a biopsy. This is from the back. You can see that this second layer, the pink, is where the collagen is. That's very thick. That's the dermis. And this is just the sort of picture, the cartoon image, and the real image, just to give you an idea of how similar those are. I'm showing you those because there are other elements that relate to our structure of the face and the rest of the body, those being muscle and bone. So when we're talking about aging and the changes that can occur, maybe we should turn it down. Is it okay? He'll turn, because I'm trying to move this thing and I'm maybe just turning it down better. Thank you so much. We've talked about the 3 layers of skin, and then just to show you the changes that occur in the sort of scaffolding that we all have with time, these are all expected changes, involve muscle and bone as well, so deep to the skin. So, and this is important to think about when we're talking about outcomes from surgery, including cosmetic surgery or cosmetic procedures, over-the-counter things we're buying. We can't affect, of course, the bony changes that are happening. So just as one example, look at the size here of this of the sulcus from the cheekbone, the zygomatic arch, down to the jawbone. You can see how much hollowing out happens with time over here. That's just normal. The eye socket, also the bone resorbs a bit with time. That's why we all just have changes to our face. These are all normal, natural changes. But we don't want people to sell us products that they say are going to plump the face or things like this, because you can imagine just seeing the scaffolding, those are not going to work. One other important change to notice here is the fat distribution in a face of someone in their 20s and 30s versus the fat distribution in someone in their 40s and 50s. This fat pad, this is not a cutaway, this is actually what happens. The fat pad drops, and the fat pad in the lower eyelid drops a bit, and you have resorption of fat up here. So it's just, these are just all natural, normal changes. They occur deep to skin, and they cannot be affected by things that we put on the skin. So that helps us be smart consumers about what we can expect these products to do, for example. Now let's talk about nails. I wanted to point out a few things. Here is our nail. And importantly, when we're talking about nails and how to take care of them, let's look at the cuticle. You can see the important function that serves. That bit of dead skin layer keeps debris and other material out from under the nail. From under the skin where it could otherwise affect the nail. So we want to leave the cuticles intact. This is the skin. This is called the proximal nail fold overlying the nail plate. The second thing I wanted to point out to you is you can see this is how much nail we can see with the naked eye. But if you each look at your own finger, you can see that there is about 25% of the nail plate that lives under the skin. That is actually born from under the skin. Next, I wanted to point out to you there's no fat under the nail. That's certainly why it hurts a lot when we pinch our finger on things. And anything that disrupts this matrix, this nail plate here, is going to result in a divot in the nail or some surface abnormality of the nail. And then lastly, I wanted to point out the strongest attachment of the nail is actually way out here, but this is called the onychodermal band. Once you breach that for any reason, whether it's with a foreign body, or if you have the unfortunate circumstance to happen like during a manicure or pedicure where that gets breached, this, I like to say, lifts up like saran wrap off the top of a cake. It just comes off very easily. So it's important that we don't, for example, if we're getting manicures and pedicures, let anybody dig out under the nail, because that puts us at risk for infection. Okay, now we're going to move on to skin. Some of the changes that we see, and we already looked at the layers of skin from when we're a baby. This is actual histology here, actual biopsy, and this is an actual biopsy image stained with a routine stain called hematoxylin and eosin. You can see this second layer of skin where we had the collagen is literally a different color. And that's because with sunlight, we get breakdown of elastic fibers and collagen. And it's literally, this is affected by ultraviolet light in the UVA spectrum. So UVB, ultraviolet B, can really just get to this top layer, and UVA gets deeper. So we'll talk more about that later when we get to photoprotection, but just to give you a visual, this is actually a change, a physical, visible change that happens in the skin. And the second thing I wanted to point out here is with time, this dead skin layer, this, we call it a basket weave appearance of a skin layer. It's a dead skin layer called the cornified layer. That actually thickens and the cell turnover slows down, so that things that can remove that will better minimize things like the appearance of wrinkles and brown spots and things like that. This is not a cosmetic talk, but just to give you sort of a visual of things that happen with time. Those are very typical in the skin. This is one of multiple famous images that you'll see if you Google photoaging. And I just put it on here because it really shows the importance of ultraviolet A in causing these deeper wrinkles. And the importance there in damaging the skin is that UVA itself actually does not cause sunburn. When we're talking about sun protective factor, we're talking about UVB. The ability of a product to block ultraviolet light in the UVB spectrum. UVA gets deeper than UVA, and it causes that breakdown of collagen and elastic fibers. So this is a truck driver, and you might all know, just in terms of a practical pearl here, that when you're driving your car, the hood, the windshield, the front windshield blocks ultraviolet light A inherently, but the windows on the side do not. So you can, as you all may have, some of these products that you can apply to the window on the side to block UVA. This is truck driver had no protection from UVA. So that's just a visual of what happens without sun protection. Okay, let's talk about photoprotection. So I like to tell people when they come in for a full skin exam, I like to say, well, there are some things that we can change and some things that we can't. We've all got our genetics that we are inborn with, and there's no changing those, and we can't turn the clock back and go and put, sun protective clothing on when we were 40 or 30. So we can affect what we can affect now. The things that are in our control are current photoprotection and early detection. And then there's a very hot topic in medicine is chemoprevention of skin cancers and precancerous change. So let's start by talking about the things in our control, specifically photoprotection. So when we talk about skin cancer is the most common, non-melanoma skin cancer is the most common type of cancer, period. And in fact, non-melanoma skin cancers are about 3.5 million of these diagnosed per year in the U.S., that is a number greater than all other cancers combined. So this is an extremely common cancer. These are, for the large majority of them, local skin cancers that don't go places in the body. They do not typically metastasize. Again, this is the non-melanoma group. There are exceptional cases, and particularly special populations like people who have had transplanted organ transplantation and are otherwise immunosuppressed, or have a skin cancer in a really bad spot, like within the ear canal, things like that, where they can metastasize. But for the most part, these 3.5 million non-melanoma skin cancers per year do not metastasize. This visual here is another way for me to show you that the yellow is these are the effects of ultraviolet light A in the UVA spectrum, and here's UVB. So you can see that UVA, with respect to our skin layers, this top layer being epidermis, then dermis, then fat, UVA gets deeper, and it causes more damage deep in terms of dark patches, wrinkles, loose skin because it breaks down elastic fibers and collagen, and the appearance of premature aging. It works synergistically with UVB to cause skin cancer. And then UVB is the ray that causes sunburns and eye problems like cataracts and glaucoma and macular degeneration. So one of my good friends is an ophthalmologist, and we worked together to do a community education talk months ago, and her kiddos, were, once they were born, she put sunglasses on them. So she's a big fan, and it's very important to be thoroughly protected. So in general, many of you know these since you've seen your dermatologist, and one thing that we're very sensitive to here on the islands, and hopefully all our visitors is active ingredients and how to use sunscreens in a environmentally green way, and specifically avoiding, in general, chemical sunscreens. We want to use zinc oxide or titanium-based sunscreens, don't we? And avoiding aerosolized sunscreens, because the chemicals that allow the sunscreen to be aerosolized also can get into the water and into the sea turtles, for example. So avoiding those and sticking with, we call those the physical barriers, or the particulate sunscreens, the ones that are zinc oxide or titanium dioxide. And then lastly, we'll typically want to avoid nanoparticles, nanoparticulate sunscreens. So more of the physical blockers are better for our environment. Actually, just in general, sun protective clothing is probably the best for the environment. But these are things that we think about. And you might all already familiar with the self-tanners. That's literally just a sugar molecule, dihydroxyacetone. There are many of these self-tanning products that come in creams and foams and other things, and you can actually have them professionally done. All that is a sugar that stains the skin, that dead layer of skin I showed you before where it gets a little bit thicker the older we get. It stains that, and then that will eventually, of course, slough off. I didn't mention before, but I'll mention it now. We might all already know that the top layer of skin that I showed earlier, the epidermis, this layer, takes about a month to turn over. So that, for example, when you're using those self-tanners, that will slough off and you reapply them. Or if you've ever had a skin rash and then the rash goes away, you might notice your skin is peely. That's why that happens. And when I say a month to turn over, I mean a month for the cells at the bottom of the epidermis to literally move up in the top layer of skin and shed off in that dead layer. That's what's happening. It takes about a month for that to occur. So we've talked about our sunscreens and the broad spectrum. The other thing I like to do in terms of just helping my patients be good consumers is to recognize that SPF 30 actually gets you about 97% of your benefit from sunscreen products. So you might have noticed that the higher you go in SPF, the more expensive it is. You can stop at 30 because you're really only getting a very small incremental benefit from going any higher than SPF 30. So pick a sunscreen SPF 30 with zinc oxide or titanium dioxide or both. I don't have any stocks in sunscreen companies, but some really great gentle ones, especially that are widely available. Amazon and things would be like Vanny Cream, Blue Lizard, or any generic sunscreen that has an SPF 30 with zinc oxide or titanium dioxide. I love generics, right, Daddy? Pharmacist father-in-law. So, and then just in general, about a palm size is what you need for your arms, legs, and anything outside of the swimsuit area is about it. Replenishing every couple hours. That SPF factor you might know relates to the duration that you can be out beyond the time when you would normally burn. So, but of course that's affected by, are you in and out of the water? Are you in and out of sand? Are you toweling off? Are you wiping it off? All these kinds of things. So at a minimum, reapplying every 2 hours is a good general approach. Okay, let's get to early detection. In general, what I'd like to say about that is that if we haven't had skin cancers, then there are no U.S. specific guidelines for how frequently, if at all, you need to be seen by a dermatologist. I get that question a lot from patients I'm seeing for melanoma follow-up, and their sister has never been to a dermatologist. Should that person be seen? Things like that. But once you have had a skin cancer, yes, there are very definite guidelines we follow, and we'll get into that. Having said that, we do always, in general in dermatology, first-degree relatives of someone who've had melanoma or other skin cancers. That's something that's certainly a very reasonable indication to come in for a head-to-toe skin exam. But in terms of concrete, objective, standards of care guidelines, once you've had a skin cancer, yes, we have specific guidelines to follow. If you have not, it's more of a general gestalt. Your family history, how many nevi do you have, are they atypical? So that's more of a soft, subjective guideline. Okay, so when we're doing our skin exams, in general, when you see your dermatologist, I'm sure all of you, they remind you, look at your skin at least once a month. That way you'll know what's normal for you, and you, being the person who's going to see yourself the most, and maybe with your partner's help, will be able to catch things early. So I say, we have brochures in every clinic, and these go through, look at yourself, head to toe, every nook and cranny, in places that you can't normally see very well. Grab a mirror or a willing partner to help you, and then look at their skin in return. And what are we doing here? We're really looking for spots that are changing in one way or the other. That's the easiest to remember. There are many specific features for various skin cancers, whether it's melanoma, basal cell, or squamous cell, or other skin cancers. But in general, the easiest one to remember is it changing? No healthy spot should be growing, changing color, changing shape within a 1-month period. So that's where if you're looking every day, you might miss subtle changes, but typically if you're looking once a month at your skin, head to toe, that's a very healthy approach. Lastly, in terms of prevention, we talked about photoprotection, we talked about early detection. There is a lot of interest, of course, in chemoprevention. And finding data, and acquiring data is very important so that we can have some evidence-based guidelines. One in particular that has gained over the last 5+ years some significant traction is the use of nicotinamide. This is actually a vitamin B3, is vitamin B3 in an amide form. So this has actually, I'm not promoting this for anybody's use, but I wanted to introduce the topic of chemoprevention. If you ask your dermatologist, they will be familiar with this. This is, again, a vitamin B3, niacin being B3, and nicotinamide being the amide form of that. So readily available as an over-the-counter supplement specifically. And this was a study that was actually a randomized, double-blind, placebo-controlled trial that was done in 2015 based on 2 prior double-blind, placebo-controlled trials that was looking, these were phase 2 studies. You'll remember that phase 1 is safety, phase 2 is efficacy, phase 3 studies are looking at is it better than our current standard, and then phase 4 studies are more long-term monitoring once a product or a medication has been introduced to market. So this phase 3 study, published in 2015 in the New England Journal of Medicine, looked at nicotinamide dosed 500 milligrams twice per day and noticed a reduction, a significant reduction by 23% in the rate of new non-melanoma skin cancers in the treatment group versus the placebo group, the group that was not receiving any nicotinamide. That effect went away once the medication was discontinued. There was no difference in the adverse effects from nicotinamide. We don't use niacin, the parent vitamin, because that causes significant flushing, as you might know, and so that is less desirable for that, from that standpoint. But nicotinamide, for example, in our transplant population and people who have many skin cancers is one essentially minimally invasive, useful approach to limiting their rate of getting new skin cancers. So just to introduce the topic of chemoprevention. So we've talked about how frequent skin cancers are, and you might all be familiar with the National Comprehensive Cancer Network. Your cancer center here is part of that and uses those guidelines for all cancers in terms of approach to therapy. Skin cancer is no different than those. So we have very concrete guidelines related to how widely to excise a melanoma based on how deep it is under the microscope or under the when we've taken our biopsy and things like that. So these are the guidelines I mentioned that we talked to. You can get, if you're interested in Googling or reading a little bit more about those, those are where you would find those guidelines. So when we're looking at our early detection of melanoma, I mentioned earlier that we're looking once a month, and we're specifically looking for these things that are the A, B, C, D, E's of melanoma. These four are more difficult to identify when you're not used to looking at melanomas, particularly if you have other spots on your skin, things that I'll show, let's see if I have it next, like these. These are called seborrheic keratoses. These are called hemangiomas. This is another flat seborrheic keratosis. This is melasma. Here's lenigo. So there's a lot of brown spots, red spots, other spots on our skin, right? So it can be difficult to pick out, is this a seborrheic keratosis or is that, should I be worried about that? But I tell my patients, first of all, number one, anything that you're worried about, I want to see. Anything that you think is abnormal, I'm happy to take a look at it. I'd rather look at something and say, nope, that's healthy, you're good to go, than have a delayed diagnosis, because we know, as the next slide will show you, without a doubt, that early detection is critical in survival rates for melanoma in particular. Next, I tell patients anything that's itchy, painful, those are all things, and bleeding, that aren't on this list, but that are also indications that it'd be fabulous to have your dermatologist take a look at. And on this list, the easiest thing to notice is if something is growing on a month-to-month basis. Those healthy spots should not be growing on a month-to-month basis. Those should always be looked at. So I mentioned about early detection, and this is just this is a survival curve that shows you related to stage, and this is I'm going to use the word histologic stage, meaning microscopic diagnosis stage of melanoma, that the later we catch things, the worse our prognosis is. And here, for example, just to give you an idea, T1, so T0, a histologic stage of 0 is that melanoma in situ, top layer of skin I was talking about. Those people do exceptionally well. For example, I don't want to go into too deep into detail, but I know this is a very curious bunch and very bright bunch. So the T1 means in the newest staging that we are less than 0.8 millimeters deep, and that's under the microscope. That's not looking at the skin like this, but this is, you take a biopsy, you look at it under the microscope, so very thin. So here, this is a greater than 4 millimeter deep melanoma. So a very deep one. So the quicker we can catch them, the more shallow they are when we can catch them, the better their survival is really what I wanted to show you there. Next, let's talk about the most common type of skin cancer. This is the 3.5 million per year. These basal cells are actually the most common type of skin cancer of all kinds, not just skin cancer, of most common type of cancer of all kinds. These are relatively slow growers, but of course they do bleed and they will just destroy whatever's in their way, so you need to treat them. And in particular, what's important about these is how they're growing under the microscope. That really helps you determine what your options are for therapy, that you're going to determine in conjunction with your dermatologist. What of these treatment options do I want to have? Just like Lewis was talking earlier, I've got these options, not this one, not, okay, yes, ablation here. Well, for these, for basal cells, they can be growing in multiple patterns under the microscope, and that helps us decide what type of treatment, whether it be excision, or Mohs surgery or other options. What are our options for that particular cancer? Squamous cell cancers are a bit more aggressive. You can see this white stuff, that's the dead skin layer. These cancers, squamous cells, by definition, they are skin cancers of cells that keratinize. So they make this white stuff. That's the dead skin layer. Those tend to be a little more tender. They're a little more aggressive than basal cells in general. And we think about what it's growing, how it looks under the microscope, where it's growing, what else is in the way that it's going to destroy, how big is it, and other factors like patient general health. Are they someone who can tolerate something called Mohs surgery, other things like that? So it's an entire conversation with multiple factors at play. We talked about some of these other spots. I mentioned them earlier just in context of us being aware that we have lots of spots on our skin, and I like to say I can name them all, but what we care about is benign, healthy. Those we can ignore, but we want to pick out the unhealthy ones. Just to give you a name, these thickenings of the top layer of skin are called seborrheic keratoses. I like to say I can find at least one of them on everybody over 40, and none of us wants them. We just, it'd be nice if we had a cream to put on to get them to just fall off and not leave anything behind, but they're just so common. They're not warts, they're not moles, they're not cancers. They have no increased risk of turning to cancer over even totally normal, healthy skin. They're just nuisance bumps. They can get inflamed and itchy and certainly can be removed, but if they don't bother us, they don't have to be removed. These are little angiomas, little vascular blood vessel growths. They're totally benign, also not related to anything going on in the skin. So common that, again, I can find probably one on everybody over 40. Very, very common. And then these are some of the photoaging things we talked about earlier, but just, like, for example, large lenticels on the face very frequently get a lot of attention from us in dermatology to make sure that they're not melanoma hiding in there. And you would expect, I'm sure, that on, for example, sun-damaged skin, we can see those healthy spots, for example, a seborrheic keratosis, and on that same skin, for example, coincident with it, a melanoma in situ hiding in there, or a basal cell hiding in there. So that's where that, I tell patients, even if that spot seems like it's been stable for 5 years, but it starts changing, those would be reasons that it might be changing. So some approaches to biopsy here. You can see that depending on what your dermatologist thinks of the lesion, you will be offered some options of biopsy, including a shave biopsy, a punch biopsy, an incisional biopsy, which means taking an elliptical, usually a football-shaped excision of the lesion without trying to get it out with a margin of normal skin or anything, or an excisional, meaning trying to get the whole thing out, if it's reasonable to do based on size. So some of those definitive therapies I talked about earlier, where I said, well, if we have a basal cell, it depends how it's growing under the microscope, what our options are. Those options are going to be excision, and here's that football-shaped excision. The reason it's got to be this shape is because to get a circle closed flat without the edges raising up, we call those dog ears, we've got to lengthen that excision so that it's got to be, for our engineers in the room and our math majors and physics majors, we've got to make it about 3 times as long as it is wide to get it to lay flat without dog ears. So that's how an excision works. Electrodesiccation and curettage is a treatment of basically burning and scraping the skin cancer. with heat. And Lewis talked about destroying cancer with heat. That certainly works in the skin as well, as long as it's superficial, so a shallow skin cancer. And then rarely, for example, big tumors, radiation is an option. Topical medications, for example, one called imiquimod, or the brand name of that is Aldera, is also an option, also just for superficial skin cancers. And then rarely there are medications that are used, but those again are very rare. I'm happy to answer questions about those later, but they're very rare. So this is an example where this is a basal cell skin cancer on the lid margin. Certainly we can't just excise this and expect that we're going to have complete tumor removal with negative margins, and we certainly need to be, this would be what we call a critical location. So I wanted to mention Mohs surgery. This actually was developed at the University of Wisconsin in Madison by a Dr. Fred Mohs. Now it's the international standard of care for skin cancers in certain parts of the body. And what happens is the lesion is removed, and you can see here we've talked about the top layer of skin, this darker pink color, and that's the epidermis, and the second layer of skin, the dermis, is where the cancer is invading to. Well, this Mohs surgeon takes a layer, looks at it under the microscope and says, oh, okay, well, most of this is clear now, but here's where I have to go back and just take this little bit. So it's tissue-preserving surgery, where it's very targeted, and they're looking at 100% of the margin of the specimen submitted. So this entire margin is evaluated in real time with the patient in clinic. I don't do Mohs surgery. I work at UW where we have 5 Mohs surgeons. But in any case, then that surgeon goes back and just takes this. Oh, now there's just a little bit left here. Then they take their third layer. Now they have it all. Now they close this hole. So that's why Mohs surgery exists. It's very targeted. And you might say, well, why don't we use this for everybody? It's very labor intensive and very much more expensive than just doing excision. So they're actually, based on utilization and the expense of Mohs, there are actually some appropriate use criteria that have been developed and that have to be met sometimes for insurance companies to pay for it, but it's really standard of care for skin cancer of certain types in certain parts of the body. It would be part of your conversation with your dermatologist. Is this eligible for Mohs? M-O-H-S. That's, again, the last name of the surgeon who described it. So this last part here, last couple parts, relates to what I was talking about for healthy aging. You could spend thousands, tens of thousands of dollars on things, couldn't you? And they'll say, oh, it volumizes the skin, it does all this kind of stuff. And you know, based on what we've talked about, that really what we're going to affect with topical therapies, anything that you can get in the store, any store, drugstore, or counter at a mall or something, would be top layer of skin issues. And really, if you're going to spend what you spend in those arenas, you might as well go to the dermatologist and get a generic medication that's actually going to work, that we don't have any stock in. These are things that you prescribe, and I'll tell you in a minute what those are. So it's just about being a smarter consumer. We really just think about, well, what's the primary pathologic process here? What's going on? And then what are my options to fix it, to address it? So how do we think about that? I already broke down earlier the top layer of skin, the second layer of skin, the third layer of skin, and deeper issues. When your dermatologist is looking at your skin, if you care about, if that's a reason you went to the dermatologist to say, you know what, are these brown spots healthy or not? They say, oh, they're healthy. Okay, well, I don't like them. I'd rather they not be there. That's really the question. And there are many minimally invasive things you can do. And again, this part of the talk is really just to say, don't waste your money on a lot of stuff that doesn't work. Just ask your dermatologist and they'll tell you what to get. So the things that can address most of the photo aging issues are right here. Sunscreen, zinc and titanium dioxide, those are physical blockers that will block both UVA and UVB, because we know UVA is photoaging, okay, and we don't block UVA with a lot of the chemical sunscreens. Really the UVA is blocked with the physical blockers of zinc and titanium. Retinoids, so one very common one that comes generic called tretinoin. Actually, multiple of the compounding pharmacies will compound that for you, much less expensive than even having it prescribed and getting generic tretinoin. So, for example, I've prescribed for a lot of my patients tretinoin 0.04% cream, and they'd put a pea-sized amount on their finger, dot it on the face, rub it all in at night, go to sleep, don't worry about it. If you forget to wash it off, it doesn't matter. It works great. We actually use that for minimization of precancers as well. It doesn't work as well as things like liquid nitrogen and peels and other things, but it is an adjunct and helpful. And then you can have peels done of various sources, various types, like trichloroacetic acid, glycolic acid. It's all about what fits for you and how much downtime you can put up with. And then resurfacing. So, for example, laser, other things. But in any case, you get the idea that really most of the lentigos, shallow wrinkles, breakdown of deeper, like collagen and elastic fibers, really we're going to affect those with the things that I've listed here. So the over-the-counter thing that you would, that we'll all spend our money on is a zinc or titanium dioxide containing sunscreen. And the other things you might as well get by generic prescription at a pharmacy, including a compounding pharmacy, because they work better than what's over-the-counter anyway. I wanted to mention a couple other things here, specifically 5-fluorouracil. That medication is fabulous. It's a wonderful workhorse medication. It's a prescription. 5-fluorouracil is available. It's a chemotherapy agent. It actually comes intravenous for squamous cell or cancers inside the body, but we actually use it on the skin for lots of those precancers or actinic keratoses. So that's a medication to be aware of. It would be an option when you have lots of precancers on the face or arms or hands, as opposed to liquid nitrogen or peels or things like that. So just something to be aware of. Targeted chemotherapy. And then I wanted to mention dry skin care, because I know on the islands you have no trouble with dry skin, this beautiful, humid climate. But when we go visit our relatives at holiday time, and we are January in Wisconsin, holy cow, every third patient that I see comes in with fissured fingers, dry skin, itchy skin, and really very simple. I tell people on the mainland, when we turn our heaters on, that's when we have to up the gentle skincare regimen. 2 things, that's all we have to remember. Leave the moisture that we have there, meaning don't wash off the natural oils in the skin, and reseal the skin with moisturizers. So this is what dry skincare looks like. It's very flaky. The second layer, the skin cells aren't holding together as well as they should. This is all in your handout about how to avoid dry skin to start with. So we want to use neutral pH soaps. I have some examples on the next slide. We want to take tepid, not super hot showers, because when we're using hot showers and scrubs, we're removing the natural oils in the skin. And then we want to just put back moisture after, for example, we wash our hands or we take a shower. Within 3 minutes, seal all that nice moisture that your sponge, your top layer of skin is literally a sponge. It will soak up water. All you have to do is trap it in there. One of the best, cheapest moisturizers is white petroleum jelly. Love it, love it, love it. Put it on your hands, for example, before bed. If your hands are dry, put some white cotton gloves over the top. In the morning, you'll be 80% better. Great stuff. I put pictures up here just to show you that, it can be so confusing to go to the counters in the drugstores and things. You're like, well, what the heck am I supposed to buy? You're looking for active ingredients, which I had on the previous slide. These are just general moisturizers with glycerin and other products in them, dimethicone, that just moisturize, that just trap in the water that's already there. Lactic acid and urea actually draw water into the skin. So these would be for very, very dry skin. These you have to put onto damp skin to trap the water in that's already there. These can be put onto dry skin because they'll pull water into the skin. Okay? And then nail care. So very simple. We'll remember that the cuticle is very important. It keeps the environment out from under the skin where we don't want it to be. We'll remember that Nails should be generally cared for by clipping them straight across and rounding at the edges to limit ingrown nails, and that polishing is fine. It's actually really the removal of the polish that's the problem. So try to only remove polish every couple of weeks if you have the option. Trauma, this is all from trauma. You can see here how the cuticles here have been removed with a cuticle trimmer and pushed back. So all of this ridging is occurring because of the pressure being placed on the nail as it's growing and trying to come out. So this is going to take 3 millimeters per month is how quickly nails grow. So this is going to be about 6 months for that ridging to grow out. We just have to be patient. I wish we had a crank that we could make nails grow more quickly, but we really don't. So in terms of caring for your nails, we've talked about a lot of these things. And if you are someone who has very dry cuticles or peeling of the skin, you care for that just like you would dry skin. Moisturize at night. Again, that's all in your handout. I wanted to point out just on these next 2 slides a wonderful resource. The American Academy of Dermatology is where you can find a dermatologist. There's literally a Find a Dermatologist page. Almost all board-certified dermatologists in the United States and many internationally are members of the AAD. And this has wonderful patient resources on it. You name it, it has handouts on eczema, on psoriasis, on rashes, on nails, on hair. You name it, we have patient education materials. So a wonderful, obviously, incredibly credible resource. I think there's a lot of information out there and hard to know where to start. So today we've talked about thinking like a dermatologist, photoprotection, early detection, healthy aging, dry skin care, and nail care. And these are my kiddos with obviously their grand, Lewis, who's now 18, and Audrey, Virginia, who's 20. Thank you for having me. Mahalo.